I would now like to introduce our esteemed moderator, Dr. Donald Lee. Dr. Lee is a specialist in family medicine at a private practice here in Hong Kong, and he is the president of the World Organization of Family Doctors. And he's also the past president of the Hong Kong Academy of Medicine. And he serves on many Hong Kong government and public health bodies. And Dr. Lee, forgive me that I will not list out all of your esteemed appointments. You all would be really impressed if you would see the long list of the prestigious positions that he holds. But just to name a few, he is the chairman of the governing committee of the Hong Kong Jockey Club Disaster Preparedness and Response Institute, and he's an advisor of the People's Republic of China in general practice development and enhancement. So with that, I will turn over the stage to you to present our keynote speeches.
Good morning, everybody, and thank you very much for the opportunity as the President of the World Organization of Family Doctors to participate in this most important forum as moderator. Actually, we have three even more prominent speakers, keynote speakers, which I will introduce. I'm also happy to have the privilege to make some concluding remarks and talk a little bit about the role of family doctors in heat and health. But first of all, we have today with us Professor Emily Chan, Professor and Assistant Dean of the Jockey Club School of Public Health and Primary Care of the Chinese University. She and her team at CCOUC have been doing climate-related health research in Hong Kong, a major subtropical urbanized context in the region since 2008. Specifically, their team had published over 30 studies which helped to map various health outcomes and related health risk patterns. These studies provide global community better understanding of how subtropical cities may be affected. The study series have provided important information for the Hong Kong Observatory to build their new warning system in 2015. And she will be speaking on heat-related health impacts in subtropical cities, global overview and research frontiers in Hong Kong. Our second speaker will be virtual. She is unable to join us, but she is Christie Abbey, who is the director of the Center of Health and Global Environment at the University of Washington, Seattle. She has been conducting research and practice on the health risks of climate variability and change for over 20 years, focusing on understanding sources of vulnerability, estimating current and future health risks of climate changes, and designing adaptation policies and measures to reduce the risks of climate change in multi-stressor environments. She has been an author on multiple national and international climate change assessments, and she co-chairs the International Committee on New Integrated Climate Change Assessment Scenarios, facilitating development of new climate change scenarios. She is unable to come to Hong Kong, but will make a video presentation on facing the future of a warming world. Our third speaker is Virginia Murray from Public Health England, and she is the head of Global Disaster Risk Reduction. She has been a key international leader in linking various global initiatives, particularly the Sendai Framework for Disaster Risk Reduction, to emphasize on the importance of science in building the knowledge bases to mitigate temperature impact in population. I'm sure we'll learn from her about the challenge of health impacts from heat and other extreme events as she speaks on making a difference in the context of disaster risk reduction. So maybe without further ado, I call upon Emily to make her first keynote presentation. Emily, please.
Good morning and welcome to Hong Kong. Thank you, Donald, for the kind introduction, and I'm very glad to be here to share with you a topic that I have been working on with my team and many of the colleagues in this room. But with the next 20 minutes, I hope to be able to share with you what may be some exciting but worrisome findings we find in Hong Kong, a subtropical city. But allow me, let me start by showing you this picture. This is a good day. Very good weather, and this is a picture shared with me by my colleague from the observatory. It's a good way to look at Hong Kong. Even though this is health and temperature, we work closely with our urban planners, our architects, in order to understand how this whole impact may be working on. And I will show you a few of the things why I bring out the importance of the built environment. I represent not myself, Team Hong Kong, because there are quite a number of studies that I'm going to share during the discussion about, the findings that was beyond me, myself, my team. But let me start by I have to do some PR of my team. I'm from the other university, the Chinese University of Hong Kong. But we are partners, definitely, because we won't be able to work on this particular topic by one university. But in any case, I belong to the Faculty of Medicine, and also, of course, public health. We have an academic team that have been working on this topic for 10 years. And with the area of work, we also hosted in a collaborating center, CCOUC, as you can see from the slides. It's a collaboration effort between Oxford University and Chinese University of Hong Kong. And the important thing I want to bring out from CCOUC is the fact that we are also part of the other agenda, the WHO agenda, because there is a thematic platform that targets health emergency disaster risk management, and naturally climate change is part of it. And for good reason. My other co-speaker, Virginia, it's actually another co-chair of this group, so you can imagine the influence is there, the discussion is there. But the idea is that, traditionally, topics has been quite compartmentalized. Disaster people may mention climate change, but with the efforts, or at least the future, the idea is that we will work together. And this is definitely part of the bigger package. How do you manage risk, health risk? With all the extreme events that is going to affect the global society for the next decades to come, or many decades to come. And this is just to put into perspective, the evidence that we're finding here, even for climate change, will fit back into many other global agendas. So yes, we talk about how heat is affecting community in health, but the same evidence will be useful to think about SDGs, to think about Sendai Framework, and many others, which Virginia is going to talk about later. And as Donald has pointed out, the other many endeavors that even the Hong Kong community is working on, it's disasters. We are actually having a big collaborating institute with the Academy of Medicine. So there are many things. But let me go even further. For audience in this room, how does public health address this issue? Perhaps public health people talks about prevention. And we have this whole hierarchy of prevention. And without going too much into detail, I just want to highlight one of the major discussion, at least as a policy agenda, is about impact-based warning. And for us in public health, that belongs to primary prevention. And primary prevention is up there, is when before things becomes ugly, how do you prevent it? But in order to do it, we have to have evidence. So my next 16, 17 minutes is going to talk about what kind of evidence we have generated so far. Okay, this is the starting point, but allow me, because as far as I would go for the meteorological discussion, because I am from the medical discipline, but this is what I will share with you. There's of no doubt temperature is increasing. How much we are not sure yet, but it's going to not to be very pretty. And if I look at the world, just purely by temperature zone, there are roughly 4 or 5, depends on which category you're looking at. Hong Kong belongs to the subtropical community. Okay, so if you look at it clearer, this is the yellow parts, are communities which are living under subtropical environment. We are closer by temperature or the climate condition to Mexico City. Okay, interestingly. But interestingly, the reason I bring this up also, whatever evidence we find in our community potentially may have some meaning to other subtropical communities as well. So that was how we hope to be able to contribute to the global environment. And the case of Hong Kong. So what about the case of Hong Kong? Hong Kong, now where you are, it's on the southern tip of China. It's a city. There's about 7.45 million people. We have made three main territories, subgroups. Historically, we have an island, we have a peninsula, and we have like an even bigger chunk of land. It's one of those communities that human beings manage to outdo the environment. If I talk about health risks, we used to be very malaria prone. Okay, during the early colonial days, about 250 years ago, I would tell you that the biggest cause of mortality is malaria. We don't have a single indigenous malaria case anymore, but we have other. We are at the risk of having dengue. Okay, but essentially, that was how far we have conquered our environment a bit. But as a city, it's a subtropical environment, and we have a very distinct summer. That it's hot. And if I look at this is just to tell you it's subtropical. Our winters rarely goes below 10 degrees. We do have cold winter, but we don't snow. Just to put into perspective, climate change, temperature does affect us. From my good colleagues from Observatory, they share that in 2017, which is about a year ago, 3 months ago, we record one of the hottest summer day with 36.6 degrees Celsius. Okay, so it's quite hot for us. Very hot, not quite hot. This is just to show you a big picture. If you look at the past few years, the bars are year, every day. This is as far as I can show it by days, by heat, okay? And we can see that most of our hot days are actually in the summer, from May to October. But it's interesting to look at. It's a bit counterintuitive, but our mortality, daily mortality, is not during the hot days. And we have many evidence to show that hot is important. And today, I remember we talked about heat, but just to put in perspective, most mortality associated with temperature is actually concentrated in cold times or cold days or cold months during our year. This is just natural pattern, no analysis, just to show you by depth. Okay, but later I will show you some interesting patterns of modeling that we find and see some interesting association with how temperature is affecting our health outcomes. Okay. And there are many things of Hong Kong aside from a subtropical city. We have a lot of transient migrants. That means visitors, like many of your good self. We have actually 10 times as much people going through Hong Kong than our own population annually. Okay, and we have one of the highest income inequalities, one of the highest population density. We are 98% urbanized. And we actually faced one of the city with the highest ambient temperature increase. Okay, that was more self-created because of how the context may be, but we'll show you. This is the setting. High density living you can find in many parts of the world, in cities in Africa, in India. But our cities are strange. We're vertical. And there's not much modeling around to understand how vertical city may affect communities. Okay, so this is one of the specialty. We may be able to go further, the three-dimensional aspect of it. We have two-dimensional, people concentrate in area. How about the vertical side? Okay, from the health side, we're very eager to look at those models and try to model further. But look at this. According to some of the ranking of the world, we actually rank as the city with the highest number of high-rise, over 150 meters, okay, buildings. And interestingly too, majority, more than 75% of these buildings are residential. They're not commercial buildings, okay? So people actually live there. People actually have to like spend lots of time in this building rather than work, okay? So that was the context. This is just another slide to show, the variation, if I may put into context. The variation of, if you look at this, we can have this is actually from yesterday. I just want to show you the temperature variation of the city. Okay, yes, we actually have to rely on the good friends of Observatory to give us the temperature. But if you look carefully too, there are variations of the city because of how potentially the topography and also the buildings. So it's not that easy to map the patterns because there are variations within the city. our good colleagues from CUHK, from Edward's team, and a number of other colleagues, actually have mapped the urban heat island maps. Okay, so that is already done. It's a very useful tool for the health people to go further with. We need it because even if we try to look at temperature, daily temperature, we need to see which part of the city is hotter, at least as experienced by people. So that was at least one interface between the disciplines. Health people can work alone. We will not be able to develop this, but we need this to do further. And with the daily temperature recording and prediction of the observatory. Climate change in Hong Kong. We are small, but we have many experience with various stuff. Just to show you that there are a range of things that are changing. Not only, but just to put in context, Hong Kong is just a city. In this region, the Pearl River Delta, where we're situated, another good team, Jimmy, their team actually highlights two important things. Aside from the general projection of IPCC, we have to look at our own region as well. We actually see that very likely, what's going to happen in the next few decades is that the temperature increase will be 2 or 3 degrees higher than the current scenario predicted. And the worrisome idea, just the climate and city urbanization point of view, is that there will be a reduce of wind speed. We need the wind speed to cool down our community at night so that people can recuperate a little bit. But the wind speed is going to reduce. And then that makes a very challenging situation. We, for the longest time, relies on the evening to make it cooler, and hopefully overall per day, ambient temperature will be colder. But in this context, we will not be able to do it. And we will constantly, 24 hours, be in a very hot situation. And actually, with Runchel's team, they actually highlight that, our urban areas cannot be cooled down. That is exactly the reason why, as from the health point of view, don't think you are going home without having any device, you're going to be able to recuperate. Also, the other important aspects, the good team has done, with Chow and also Edward's team has tried to highlight is that not only if there's one day heat, it's going to affect mortality, as we know. If there are a few more consecutive hot days, happens all together in one lot, this is going to be impactful. It's already proven by data in Hong Kong. Okay, so but anyways, all this information has summarized about the meteorological impact. Okay, that was what's happened to the community. It's hotter, less wind, more consecutive days of hot days, and we know that mortality risk is going to be higher. But that is definitely one important aspect of health outcomes. But from clinicians, family doctors' point of view, that itself is not good enough because there are good data, there are good planning tools, but we want patients to be alive. Okay, we need to plan for service. So how can we do it? So we need to look further into health outcomes. And I will share with you what we did, okay? Just from clinical point of view, in this room, maybe, there may be a few like political affiliate colleagues, but let me show you, just by simple look at the variation. Even without talking about temperature, we know there are variations of mortality. It's quite seasonal too. And so that was a pattern that we will always know from just looking at mortality pattern with just the time of the year. And we know physiological as a clinician. There are many things that will affect well-being, the temperature stress that was associated with our ambient environment. And that has many effects. For young or healthy individuals like your good self in the room, we will be able to acclimatize and survive because the physiological buffer. But if someone who is ill with underlying problems, they have less capacity, okay? So with that, it's a physiological risk. And if you look at it further from a public health point of view, not just one patient, we have many, the communities. We already can trace from different textbooks even published to talk about how extreme temperature can lead to different changes of impact of categories of diseases. What is the implication? The implication is that for clinicians, if you're working with the general practice, if you have information about the thresholds of when patients started to come to see you, you may plan ahead. If you know that who are the at-risk groups, your patients who have diabetics or who have other conditions, you can warn them. Those are avoidable admissions. Those are avoidable medical cases. So when we're trying to build this whole set of studies, we actually want to understand the problem. This is a conceptual map. When we build our studies, that was how we built it. In health or in public health, we try to conceptualize outcome is not only the tip of the iceberg, the death. We know those are very important. They are hardcore. That was the end game. People died. But we want to know who actually was severe enough to use the most heavy-duty societal resources, the hospitals, who may need medical service, who may be unwell, because for WHO point of view, health is physical, mental, social well-being, and all the way to even a change of your patterns, because we know for older individuals, they may be doing exercise every day, but because of hot, they may stop, and after stopping for 4 days, they may stop completely. So that will affect the well-being in the long term. So we want to look at every single layer. We use models, for those who are interested. I mean, there are quite a number of models that we borrow from the environmental health science to build our climate model in mortality. We were quite lucky when we started. We have a reasonable good set of database that was empowered to us by the government. Of course, we have to apply to get the data, but at least it's there. So we would consider ourselves as a head start, because when compared with many cities around the world, we do have a retrospective database for about 10, 15 years of death, or even hospital database. I mean, many communities around the world are picking up, and with their aggressiveness in building data, in another 10, 15, 20 years, it will build in a bigger format. But for us now, at this moment, at least we have the model to help us to map the impact. So this is probably the technical things that I will share. It's we have to build that model, and if I can show you, this is actually the model we use. Depends on which outcome. We can tag the mortality outcome. We can tag the morbidity outcome with hospital admissions or even clinic admissions, as long as there's data. So I just want to show you quickly some of the findings. Okay, we used the mortality, we cleaned it up. I guess the first important study that we managed to pump out about 10 years ago is the mortality studies. We actually found in Hong Kong, if temperature, I'm talking about daily temperature on average, you add up the 24 hours, if it is over 28.2 degrees Celsius, mortality will start to increase by 1.8%. Okay, so this is actually the starting point. So we know there's a clear threshold that above that particular degree, we would have increase of mortality, taking into account that every day there are people who may have other risks of dying. We already control for those confounders, but we know about this threshold. But remember this metric was 28.2 because there are other findings I want to share with you. How about, okay, let me just put into context. So how does it compare with other cities? Okay, first we want to know, is it higher or lower? And it's unfair to compare Hong Kong as a subtropical city with cities in the temperate zone or warmer climate. Okay, we are actually at our threshold is about the same. Okay, but our mortality per degree is lower. It's lower than some parts of India, than some parts of Bangkok. And we attribute it probably because of how our city may be organized. But this is only for mortality. I want to make sure. So the threshold is around around that range in subtropical cities, but our mortality is lower in at least the hot weather. Okay, and just let me show you. The other thing important about this is very complicated, but let me highlight to you. This is just to show you the first two lines about young people for our community, because it was highly surfaced with many structure. The younger population, we honestly don't see too much of a significant impact. But for the older ones, 65 or above, what we actually found is that, when compared the least deprived to the most deprived, in fact, all community, overall, the older people are affected by cold and hot, okay, when they are over 65 years old. But once they get above, when it was the hot temperature, only deprived individuals are significantly affected. So this shows the social inequalities, okay? So put the long story short, in hot weather, the older individuals, when compared with less deprived, that means the richer individuals, they are definitely more significantly affected. It's proven by the model and the study. Okay, so hot and cold are important, but the hot temperature does make a difference to a social demographic inequalities impact in Hong Kong. Okay, but that many cities can do. Our special area is because we're able to map the hospital admissions. Hong Kong has a very interesting aspect. Our hospital, 87% of hospital data is collected within the same system. okay, because of how our services are organized. And because we managed to convince, at least back then, to collect the data for exactly the same number of years for mortality, we managed to build a subset of studies using the same model. We look at how hospital outcomes may be affected. We actually find another interesting aspect is that for hospitalization, the most expensive cost in the society, we actually find the thresholds a bit higher, is 29 degrees. That actually makes sense, at least from explanation, because usually the weakest group in the society, because of physiological inability to manage, they may die. And for those who can survive a bit longer, I mean, we usually see the temperature increase or the threshold is a bit higher than the mortality. Having said that, so people said, well, 29 degrees in Hong Kong, it seems to be every day in summer. As my good colleagues in the observatory point out, in the old days, about 1/5 of our annual days may be above this threshold. With climate change, now 1/4. So we have more days with this temperature and with potential impact of this. And the other thing to point out, in mortality, I mentioned, colder days would harvest more death than hot days. But once you get to hospital admissions, it was very clear that in hot days, we have more people getting to hospital than colder days. So by service burden point of view, hospitalization, heat is definitely an important indicator. Okay, so that is something proven with model comparison and also with the same set of community and data. There are many, we published many studies about it, and this is just some aspect of it. I mean, I don't have enough time. I'll share a few interesting ones. One aspect is asthma. Okay, it's in the study that we published. I won't ask how many of you has underlying asthma in this room. In Hong Kong, according to our government statistics, we estimate about 5% of our population, anywhere from 22 years old to 70 years old, will suffer from asthma. That gives us a big number, 330,000 people. Okay, so and for people with asthma, they probably would know they have that risk. But essentially, if you look at, the impact, it's very clear that we know temperature make a difference in cold and in hot temperature. But because of the focus, we talk about hot temperature, okay? And we know that above 27 degrees Celsius, by the way, this threshold is lower than death, lower than our hospital admissions, people will start to get sick, and it's significant. Okay, and what is the implication? Now we have that number. I guess for respiratory specialists or family doctors, who may have patients with the asthmatic groups, they may want to start telling their patients or outreach to the patients, hey, you are going to start to not feeling exactly as well as you would be. So there are warning, and there are, I guess, communications could be done. But this is actually one aspect. And the other thing is, people potentially with diabetic patients, okay? Diabetic patients has another interesting aspect. When we compare people with diabetics, people who are not diabetic, we actually find people with diabetic has a much higher risk, okay, in having acute myocardial infarction, okay, during cold weather, okay? And compared with someone who has no diabetics. Okay, so it's again, the risk profile is proven and it was shown by the data. How about mental health? Mental health is definitely a subset study that was not studied enough and is important. What we actually found from we published this 4 months, 5 months ago, is that there are positive linear relationship. Okay, and this relationship is similar pattern as what, there's only 2 other studies in the world. One is in Toronto, the other one is Shanghai. But they have very different, city reality. But essentially what we want to highlight to you is that there are a few groups of the 3 groups up there have more significant impact. In particular, what we want to highlight is the drug-related mental disorders. Those are people who, are supposed to be non-underlying mental health problems, but because of they're using certain drugs, and the drugs is not because of recreational, they really need to use the drugs to treat their health problems. And as a result, they actually are more likely, because of temperature of hot weather, has to be admitted to hospitals. Okay, this is significant because for clinicians who are giving medications for their patients, potentially those medications may lead to temperature regulation issues. They should warn because potential one of the side effects is transient mental health or mood disorders that are associated with temperature. Okay, so there are many things to it, but it was proven not just because of hypothesis. It was proven by actual use of service. Okay, so we know overall, there are quite a number of disease categoric specific disease burden and hospital service burden. And we go as far as looking at how help seeking behavior may be associated. And we also find thresholds, which will be useful for core service and hotline service too. So, after the past 10 years, we built layers upon layers. These are the evidence we put together, and we all try to circulate the evidence back to the community and hopefully be able to work together. But the last case of point I want to highlight to the audience is how we collaborate, because I think that would be the meaningful thing. Scientists do their thing. Urban planners, architects do their heat island map, help people creating thresholds. But the threshold has to be useful. Otherwise, just doing paper and just going published, no use. And I have to say, there are leaderships involved in the collaboration. I have to say in Hong Kong, it's the observatory, because they take a really leading role to work in the forefront to push. And then for us as academic, the leadership does help because at least there's a mandate for us to do something meaningful. So say two quick case. For the observatory, because of their really strong motivation to do something more, they actually, with all the models that was built, they work with the call center. Which I think some of the members of this room is going to visit. In your visit, in 2 days, and to look at how call centers in Hong Kong, calling of older people who are living alone, may be using the service and looking at the patterns of people who may end up with have to go to the hospital so that the service can be enhanced. So they map the service use, they map the outcome, and as a result, they also enhanced the service use. So that is definitely very positive outcomes, okay, of looking at the patterns and asking the community to up their service. That's one case. The other case in point is about the heat warning. Back to the topic of today, okay, the WMO and WHO, is how we can make sure the warning is useful and relevant, okay? And nowadays, of course, the heat stress threshold, we build many. We find many thresholds, but how is it be useful? It's not just, by the way, just heat threshold. It's impact-based heat thresholds, okay? So whatever you do has to be useful for the society from service point of view, okay? So I can tell you from the disaster point of view, Virginia's probably going to talk about more. We are quite far behind in that sense because typically our threshold is double the mortality. And how many hours or temperature do you have to face until you double the mortality to harvest or to do something? So for us, when we build this, the first thing to look at is in Hong Kong, we ask, what is your comfort temperature? And the Hong Kong community actually highlights to us is about 21 degrees. So it's a long way before, that they started to feel uncomfortable by temperature. This is just to show you. The green is to show you the threshold people feel uncomfortable. But in order for you to call out for the threshold, they will start to feel very uncomfortable since very, very low also a threshold of a temperature. Okay, so the idea is that, so what do we do? Okay, with the observatory, they started to have in 2000s a warning system. But the warning system, it's based on weather stress index. But because of the hospital admission study, okay, we published, which shows an excess hospitalization ratio, we work together as academics and also with the observatory, and we built the WBGT, index. Interestingly, the challenge that we have to face is not the equation itself, it's the coefficient, because we know every city may be different. So, but now we have the health evidence, we build it one after the other, and just to show you, if I may, because in your time, our WBGT, our coefficient is different from the Hong Kong index. Is a bit different from the WBGT that was studied and developed by the U.S. because the U.S. coefficient was developed for the Marines. They do it when they were trying to test in physiological capacity of Marines. But I would bet everyone in this room, how many of you have the physiology of a Marine? Of the Army. Okay, and in Hong Kong because of humidity. So we come up with this this new coefficient, and I mean to build a two-tier system. I don't have enough time. I'm sure in the next 2 days you're going to hear about this warning system. But I would want to share with you one thing. So do you think it's useful? How many? I mean, do you think what do you think is the infiltration of our warning system? As a last point to take home before we finish. First, let me show you this. Remember I talked about in 2017. There is a major heat in Hong Kong. We managed to do a study 2 weeks afterwards. So we are asking our Hong Kong community, how many of you actually heard about the warning? 87% of the local community actually heard about the warning. Not too bad, it's pretty good. But it was important to point out as the bring home message is that 45.3% of our responding community, there's over for 500 people responding, do not regard themselves as high risk. What even makes us more worrying is that among the 65 or above group, about 29% do not regard themselves as high risk. Okay, even they may have NCDs and all those good things. So our awareness of risk is not very high. We have all the science we want. And last but not least, is that this is another even more worrisome slide to bring home, is that if we look at general disaster risk, do people consider, at least at Hong Kong, well infiltrated by information, we try to push a lot of discussion in the community. Only 1.2% of our local community regard climate or weather is a potential threat. Okay, that leaves a lot of food for thought for everyone. That, I mean, yes, we have now science. We need more awareness. We need more considerations for people who may at risk. For instance, workers. I mean, in Hong Kong, we don't have a policy for that. Okay, outdoor workers. That will leave for the good group to think about for the next step. Okay, but in that case, thank you, Donald. Sorry, I mean, I was actually stopped for quite a number of times, but thank you for your attention. So that was a little story about what's happened in Hong Kong as a tropical city. I will leave it to my next colleague. Thank you.
Hello, everyone. I'm really sorry I'm unable to be with you at this meeting. It looks like it's going to be a really exciting and useful meeting, and I look forward to learning about what you talk about in the various sessions. This is a perfect time to be talking about how climate change is going to affect the frequency, intensity, and duration of heat events, and what we as health professionals can do about that. I'm going to provide some background on facing the future of a warming world. This figure from the Intergovernmental Panel on Climate Change Special Report on Warming of 1.5 shows the evolution of global mean surface temperature from pre-industrial out into the short-term future. You can see that there has been a steady increase in global mean surface temperature starting sometime about the 1970s, with a significant change in slope at that time. So there's been quite a remarkable shift in temperatures. Overall, the Earth has warmed about 1 degree C above pre-industrial. And you can see in the green on the upper right-hand side, the near-term projections. One of the messages from the special report is that trends in the intensity and frequency of some climate and weather extremes, such as heat waves, have been detected over time spans during which about a half a degree of warming occurred. So just within the last couple of decades, the Earth has warmed about half a degree, and that change can now be attributable to climate change, not just to climate variability. This figure shows you the near-term projections and the projections out to the end of the century under different assumptions about the evolution of emissions of greenhouse gases. You can see on the left the figure I showed you previously on what we've seen in terms of warming since about 1960. And then you can see under different assumptions of little change in emissions to quite significant change in emissions, what the timing would be with respect to the Earth warming to 1.5 degrees C. This is a transient change. This is not stabilization at 1.5. And you can see under these three different emission pathways that no matter what you assume, that warming of another half a degree will occur between 2030 and 2052. So in the very near term, we're going to see yet another half a degree of warming. That means, based on what I showed you in the previous slide, that the expectation is there'll be quite a big increase in the frequency, intensity, and duration of heat events. And this shows you projections of both a 1.5 and a 2 degree warmer world and what that could mean in terms of temperature change. And so the various climate models project robust differences in regional responses to the present day warming, to warming up to 1.5 and then between 1.5 and 2, depending on the region in question. You can see on the right very different patterns of change, that parts of the world have already warmed 1.5 degrees. There are parts of the world that will soon warm 1.5 degrees, and there's some parts of the world that will warm less quickly. So the overall conclusion is that, as I said, the Earth has warmed about 1 degree, and that each additional unit of warming means additional change, and that pattern will be uneven. There are places that will be much more affected than others. Another important conclusion from the report is that there's no single 1.5 degree warmer world, that there's a wide variation in what that world could look like. This is some work that was done for the report by Sonia Senavarotne. And you can see on the left, these are daily maximum temperatures, so the one hottest day in the year. And on the left, you can see in a world that's warmed to 1.5 degrees, what that pattern of change could look like if we are lucky and there's limited response of the climate system to that additional half degree of warming. So you can see on the left that parts of the United States, there would be almost no change at all. Some of the northern regions could actually see some cooling. Parts of South America, parts of Africa, and parts of the Mediterranean would see quite a bit more warming. On the right-hand side is the upper quartile. So this is if we're not terribly lucky in terms of how the climate system responds to that additional half degree of warming. And you can see on the right, this is a very different world. Much hotter everywhere and significantly hotter in most places. And again, this possibility is just a couple of decades away, that we could reach this on average in the 2040s. And this is part of the reason why the meeting that you're attending is so critically important, that health systems need to be prepared for a possible very large shift in temperature. And with that large shift in temperature, of course, large shifts in the extremes. On the left, you see a stylized figure of an older and a newer climate, an older climate being one that many of us grew up in. And showing that as climate changes, you see a change in the average temperature. And so you see that nice smooth curve moving to the right, and you see much more extreme heat in the new climate. In fact, what is being observed is not this nice smooth move of that curve, but the curve is being flattened and being extended to the right, which means there is a lot more extreme heat. On the right is work that was done by Noah Diffenbaugh and colleagues for the IPCC special report on managing the risks of extreme events and disasters. For this analysis, the climatologist looked at 26 world regions for June, July, and August. and asked what was, or the virtual June, July, and August, the summer period in the Southern Hemisphere, and asked the question, what was the one hottest day during the period 1985 to 2005? And then in the time slices you see in the rows, so 2016 to 2035, mid-century, end of the century, for June, July, and August, under representative concentration pathway port 4.5, are relatively moderate emissions. And under representative concentration pathway 8.5, or high emissions, asked how often would that hot day occur? Right now, we're more or less following RCP 8.5. So if you look at the figure in the top right, you can see already that we're entering a period where that one hot day in 20 years is now occurring on average every year in parts of the tropics. Even if there's a drastic reduction in emissions in the next couple decades, as agreed under the Paris Agreement, when you look at RCP 4.5, the middle on the left, you can see large portions of the world, that temperature will be occurring almost every year. And then in the bottom row, depending on the emissions, even with lower emissions, there's a significant shift in these temperatures and how often they occur. In some parts of the world, under current emissions, that by the end of the century, the coldest day in the summer will be hotter than the hottest day today. There'll be a fundamental shift in our weather patterns. Again, underscoring how critically important this meeting is to learn lessons from around the world on what works with respect to heat wave early warning systems, how to share that knowledge, and how to scale up as efficiently and effectively as possible. This figure is also in the special report on warming of 1.5. I've highlighted on the right-hand side heat-related morbidity and mortality. When you look at the figure, the zero line is pre-industrial. The gray bar across the middle is recent weather, 2006 to 2015. And then you can see the lines for 1.5 and for 2 degrees. And the question that was asked for this figure is, can we tell that climate change has affected heat-related morbidity and mortality? And the yellow indicates yes, that impacts have been detected and attributed to climate change. That occurred already. And you can see as the temperatures continue to rise that the color changes up towards red. This figure takes into account the possibility for adaptation. So it doesn't become purple, as you see on the far left for warm water corals, for which really adaptation is not an option. So it does say that we can reduce risks going into the future if we are much more efficient and effective with adaptation. And a key adaptation, of course, is heat wave early warning systems. As will be discussed throughout the meeting, it's not just heat wave related morbidity and mortality, it's also occupational heat exposure. This paper was published just a few days ago. On the top shows temperatures from the recent past, and then shows 1.5 degree increase in temperatures, and the risk of heat exposure, occupational heat exposure in the shade during the hottest part of the day, averaged over the hottest month. So you can see a very large shift in the risks of occupational heat exposure. Of course, increasing occupational heat exposure is associated with decreased productivity, and this can have large economic consequences for large parts of the world. With that, thank you very much. I wish I was there in person to be able to discuss this further, and look forward.
Thank you. What a huge privilege to be here and to have heard Emily talk about what's happening in Hong Kong and the amazing work, and to hear Chris talk about a really worrying future. I was asked to talk about making a difference in the context of disaster risk reduction in the many roles that I've been fortunate enough to play to try and bring the story to you. So inevitably, I want to start with a story. Let me take you to June 1976. You will see here, in the UK, it got rather hot. In fact, in 1976, our reservoirs dried. Our water supplies came in much of the world, much of the UK, via standpipes, so people had to go and collect their water. And the impact of that heat wave resulted in a particularly large number of deaths in comparison to other hot periods. But we didn't take health action then. We did, though, take health action after the 2003 heat wave, which I'll describe tomorrow. But let's have a look at what happened in June this year. This is this year. It's not looking forward, it's now. The world is heating up. In fact, is it just called climate change? Is it global warming, or is it global heating? I think the title of this conference, of the Global Heat Health Information Network, shows that heat is really key. In 2015, the United Nations and all its member states came together. To me, it was a miraculous year. It brought together the Sendai Framework for Disaster Risk Reduction, a framework which brings our understanding of disasters much closer along the work that had lasted for many years with the United Nations in trying to understand the impact of disasters, to link to the Climate Change Agreement, and to link to the Sustainable Development Goals. All these three, by working together, might make a difference, but all are underlined by something that works only to ministries of health, not to the heads of state, which these three voluntary agreements do, which is the international health regulations. Now, the international health regulations are really important, but they don't really include heat waves. So somehow we have to change this, and maybe there are pathways for the future. I don't know whether any of you have been to United Nations negotiations, but they're fairly stressful. But they are remarkable. They bring people together, they bring negotiators together who are an amazing group of people, very different to us ordinary health folk, to our Met Service colleagues, to our architects, who I thank so much for being our local organisers here. But the outcome was to produce the Sendai Framework. When I was there in March in Japan in 2015, this is the Sendai Framework. Very thin, very simple, but every word debated, and I'm happy to share with you copies of this, because this is what we should use as a driver for every single research project we want to do on heat. What does it say? Well, the key outcome is the substantial reduction of disaster risk and losses in lives, livelihoods, and health. We got health in there. Enjoy. We were so excited. And in the economic, physical, social, cultural, and environmental assets of persons, businesses, communities, and countries. So health was included in the outcome. So important. And health resilience was strongly promoted throughout, as the special representative of Ban Ki-moon commented. The Sendai Framework is really very simple. It has one global outcome, 13 guiding principles, 4 priorities for action, but 7 wonderfully important global targets that link closely to the Sustainable Development Goals. Reducing mortality, reducing affected people, which includes obviously health, economic losses, but also the impact on healthcare facilities and educational facilities and other basic infrastructure. It's increasing our knowledge of the risks By 2020, every country will have expected to produce their national risk register. And to increase our understanding of international cooperation, this forum is a wonderful example of international cooperation. And the seventh and most important story that Emily raised so clearly is early warning. Making sure we get early warning to all the people of the world by 2030 in a way that they can use and understand and act on. The four priorities of reaction are understanding the risk. What is the risk? And that's making countries really think about all the hazards they need to address, strengthening our disaster risk governance so we know what we're doing and why and who we're reporting to, making sure we invest in disaster risk reduction, something that is very clearly coming through from the architectural school and other places, but equally enhancing our disaster preparedness for effective response, build back better in recovery, rehabilitation and reconstruction at all levels, be they local and national, or global and regional. And one of the calls is to strengthen the technical and scientific capacity to capitalize on and consolidate existing knowledge, to develop and apply methodologies and models to assess disaster risks, vulnerabilities and exposure to all hazards. But defining what all hazards is becomes fairly complex. I just merely show you this image, and you'll notice that heat doesn't have its own special hazard, but we probably fit best under natural catastrophe, but also, increasingly from Chris's talk, under climatic catastrophe for the future. But all these come together, and we need to understand that, and one of the biggest consequences, of course, of heat is humanitarian crisis because of food security, but also disease outbreaks. So there are a lot of crossovers that exist within all these different discussions. Perhaps one of the things that I thought was most important to share with you from the Sendai Framework is this very strong message to build strategies and mechanisms for cooperation, for disaster risk reduction, in order to foster more efficient planning, create common information systems, and exchange of good practices and programs for cooperation and capacity development, in particular to address common and transboundary disaster risks like heat. So that is in the heart of the Sendai Framework, and that, I think, is what GIN is all about. Now we're in the process of actually monitoring and reporting on the Sendai Framework, and every country is beginning to submit its measurements. Does it matter? Yes, because in the UN World Data Forum, where I was earlier this year, the Deputy Secretary to Antonio Guterres, Amina Mohammed, said many deaths can be avoided with better data. And we know this isn't true, and we know we need to deliver on this, and we will be measured by it. So our ability to communicate and share is going to have to show that we've delivered something effective. So let me take you through the story of the Russian heatwave. They had a very high change in high atmospheric pressure and climate change in 2010, which led to a heat wave and drought. That heat wave and drought led to vegetation stress. The vegetation stress led to forest fires, which then led to air pollution, which resulted in increased mortality both from the heat but also the air pollution, and it was reported that approximately 55,000 excess deaths occurred in Russia, mostly in Moscow. But it wasn't just that. Crop failure occurred. And then there was the economic impact that the wheat prices went up, and then there was the query about social instability. All these things were raised in many of the discussions we've had already, but this story from Russia, I think, really helps us to understand what the consequences of these events can be. So this is why the drive from the World Health Organization and the World Meteorological Organization to provide heatwave and health guidance on warning system development is key, but also how it links to heat and climate change, an atlas that was also published, and how we can deliver these things. But these high-level things really come back to some of the leadership that WHO has been good enough to offer us. And Ted Ross reported that a healthy community is a resilient community. So we have to improve the health of our population to make sure that we can manage disasters and emergencies much more effectively. And one of the great achievements of WHO recently is it set up its WHO thematic platform for health and emergency disaster risk management, and Emily and I are co-chairs of the research group. And we hope that a very strong new message, new framework will come out by May next year at the global platform. So huge thanks to WHO and its many partners for helping us to deliver something that we think is so key. Already we are delivering things that matter, we think are really important. Health, emergency and disaster risk management fact sheets. Why do they matter? Because most people outside health think of us as a mammoth, and if they want us to talk, do they have to tweak our tail or pull our trunk? They don't know how to get to the right part of health. And that's been something that I've had from all over the world. But by providing these fact sheets on things like climate risk management, again, very brief, we help to explain this to our non-health colleagues, but also to our health colleagues in the simplest advocacy way we can. Maybe there's something here that we could do on heat. But let me look at something about the Lancet Countdown. Evidence is absolutely key, and I worked with Joy and colleagues to try and pull together the key points out of the Lancet Countdown, which was published just before the COP. So the report came out on November the 28th. We know that 157 million or more vulnerable people were subjected to a heat wave last year than in 2000, and that was 18 million more than in 2016. So we know heat is an increasing problem for the world. And picking up on the comment about occupational impact that Emily made, and indeed Chris made, 153 billion hours of work were lost in 2017 due to extreme heat. This is just last year. And because we're in China, I mentioned that China alone lost 21 billion hours of work in 2017, which is equivalent of a year's work for 1.4% of their working population. Monetarize that, and we begin to see the impacts and why governments should invest in global heat health information networks, projects and plans. Let's have a look at the figure. We can see what Lancet Countdown did to make sure that we understood what the risks are. But it's not just losing hours of work. What we know is heat greatly exacerbates urban air pollution, with 90% of cities in low and middle income countries not meeting WHO air quality guidelines. Let's have a look at this. The dotted line is where the WHO air quality guidelines are. So let's have a quick look. Anybody from India here? I thought you were. I think there's a little problem in Delhi. Can we do something about it, please? China, I can't not show you Beijing. But actually there are many China cities here. I was in Guangzhou last week, and it was pretty polluted, wasn't it? We got a bit breathless. We have to change this globally. So one of the other things that came out in preparation for the COP is this report. The Adaptation Gap Analysis from the United Nations Environment Programme, and I'm glad to say that there are several co-authors in the audience. Please stand up, my friends. Lucas, Serena, well, at least we've got some here. So this is the special chapter on heat and extreme events, of which I'm the first author, but I would indulge you all to read something like this. But what I really want to share with you is something that Joy and Lucas were very good to share with me in time for us to publish. The regional distribution of heat health action plans. Ouch. Well, Europe is about the only good boy, and we're not great, because we have 53 countries in Europe. Please, after this GIN meeting, can more of you join us? After that, can you all help us to build better heat health action plans that are useful, usable, and used? So what happened at the COP? If I'm talking about the political story, is it not important to share with you some of the findings that came out yesterday? So the COP agreed that it will undertake the rule book. The rule book is reporting. And by 2023 there will be reports, although they will be implemented by 2020. So the key deadline of 2020 is to meet the targets and set a decade ago for cutting emissions, and when they must affirm much tougher targets. The UK reported that they had reduced their emissions by 40% since 1990. So we are trying hard in the UK. How about all of us doing better? What does the science say? They've actually agreed that they will listen to the science. Hooray! As scientists, we know that this is really important, and Chris's talk is really important just now, showing that if we warm to reach 1.5 degrees above pre-industrial levels, we'll have grave consequences, not only for our wonderful coral reefs, but actually for human health. And how long have we got? That's the frightening bit. It looks as if we have 12 years left to make the difference. Not long. So we have to work now. So this forum is really timely. Thank you so much, Joy, for putting us all together with the other partners. So making a difference in the context of disaster risk reduction is key. I commend to you to use the Sendai Framework. The Sendai Framework tells a story that every country has signed up to, agreed to, and supported. Use it. Abuse it. Take it into your hearts and deliver it, because it will provide you with an agreed method for response to and recovery from heatwave, emergencies and disasters, and other public health emergencies in partnership. And it offers an opportunity to engage at a global level with stakeholders on guidance and policy issues that could impact national and local preparedness, exactly what we need to deliver. So I'd like to acknowledge so many of my wonderful friends and colleagues. It's just a start of a huge family network, which GIN should be. Thank you.
Well, thank you very much, Virginia, Emily, and also Kristie for the video. Time is running out, but give me 5 minutes to talk about some possible action, especially the role of family doctors in heat and health. First of all, we talk about health, actually. Beyond the glittering glamour of medical advances, technology, and all that, we're still dealing with people, right? People who need care, treatment, and also providers of safe and quality care. And at the front line, that's family doctors. That's why we feel that family doctors should be involved in planetary health as well. Because we are at the front line, and we understand, so we need to understand actually the relationship between environment change and emerging health risks. So thank the speakers, and also I think it's really provoked enough attention. But we as family doctors actually enjoy a most trusted source of information, Our patients will listen to us, and so we can convey messages. We can raise their alertness and also early warning and all that. Because in any emergency or disaster response, family doctors can be involved in the risk assessment part, and also in prevention, advising our patients, telling them what to do in the preparedness, but also more important in addressing issues. When we maintain regular services during times of emergencies where other medical personnel need to deal with other problems, but we still need to provide the regular service, especially for non-communicable diseases and long-term problems and all that. And also during recovery, we deal with mental issues like post-traumatic stress disorders, and also hopefully we can reduce the exacerbation of chronic diseases. Actually, the key opportunities for family doctors to intervene will really be the early warning by the communication that the health ultimately depends on the environment, both in their immediate vicinity and globally. And also to be aware of and monitor local environmental factors such as heat waves, besides, the nice warning signs and all that. So if the patient comes in even for a minor ailment, we can always tell them, you watch out, the weather is coming up, the heat is turning and all that. So basically to warn them we always talk about the opportunity of a consultation is beyond just, handling a complaint as such. And also, there's a lot of information that we can provide to our patients, such as food choices, active transport, energy choices, reproductive health, connecting to nature, reducing personal environmental impact, and also to be engaged in the community. And we can also influence policy, government policies, to handle temperature, heat, and all that. Because health arguments can be a powerful incentive and driver, in particularly at city levels, where benefits of local policy change can be seen amongst, the population. And actually, a lot of time, health arguments are not used often enough to unleash action. And then many potential advocates, specifically health actors, have not been mobilized due to lack of knowledge and tools, including family doctors, so we need to be educated. And so we seem to be disconnected with public health programs, because we were just discussing, are occupational sort of physicians the only people who can deal with heat-related ailments and all that? Obviously not. If the family doctor is willing to also ask, discuss, and understand with the patient, then there's a lot more he can do. So anyway, I think there's a lot more that family doctors can do, and I do have a little session tomorrow, which I'll elaborate a bit more on, partnership and also capacity building. But, thank you both for providing us, science-informed policies and evidence, which is most important for us to make it convincing. And we look forward to close collaboration with Jin. I think Wonka, for example, our organization, Family Doctors, we have special working groups on the environment and health, and I'm sure I'll bring back a lot of what I learned in these few days to them, and we'll be quite happy to join that network and hopefully contribute towards health, against heat. So I'll now open the floor to discussion or questions you have for our prominent speakers. Maybe I'll start by asking the two of you, what do you think the role of family doctors should be, in
Should I? Okay, let me start. I thank you, Donald. I think Donald has highlighted a very important aspects of clinicians' relationship with patients, because yes, there could be warning, but it was usually the clinicians who actually bring the severity of the situation to the patients, because they communicate and the trust. So I think, one of the things which, I highlight in the presentation is that there could be science and evidence, but we need, as a scientific community, to work closer with the clinicians who are actually the voice, the translator, or knowledge transfer agent of this. And more importantly, I think, potentially, we actually need a mutual communication from the family doctors too, because we can have the science from the data, but the patterns of what are the behavior, practiced by the patients is something that we don't know. Because right now, we actually almost like top-down type of communications. It would be important, there would be forums or workshops for us to understand from the clinicians what your patients usually do during like such hot weather. That would be surprising. Things that we find that we may address to the point what may be the needs. So we love to have more people from the clinicians to tell us about the patterns and work from the research point of view, definitely.
Thank you, Donald. To me, the clinicians are absolutely key, but so are the Met services, to be able to analyze the data, to provide the information. So the architects, so we build better, but actually there's the engagement of the whole of society. It's the story of all of us working together, and that's what Jin helps to bring for us. is this incredible network of all the different people in this room from the many countries that are represented, that if we can make this work, which we have already with WMO and WHO engagement, along with many partners, I think we'll have a very rich community, and Wonka will be so welcomed. Family doctors matter. Thank you.
Just to add, I think, behavioral changes, as Emily says, is really very important. All levels. I talked about influencing, administration, leaders, politicians, and all that. But individual behavior of self-awareness of patients themselves, and also how they take care of their family and all that, would be something that family doctors can do. But one thing that I didn't just mention is also data collection. I think as a frontline worker, we will be quite useful in awareness, basically, to see, even a patient comes in for a cough and cold, we will ask them, are you aware of heat problems? Are you aware that observatory has issued a heat warning? This kind of thing. I think the data would be quite useful for our future work. Any questions from the floor? Mr. Shum.
Thank you. So I think, thank you very much for all the inspiring talks and presentations. One very important point that Emily has raised is the awareness of the population to the health risk of heat. And also done a lot of work in identifying the vulnerable groups. But the majority of the population, we are in the society of abundance. Everyone enjoys cheap. So one thing that we have already started to cooperate with a power company is to try to encourage people to actually to make some behavioral change to save their power bills in a very hot day if they manage to decrease their consumption. But it's only a start. What else could we do to impress the population? I think that's the really most important question.
Let me start by, I think that it's a wonderful initiative, but the other important dimension for public health is the idea of promoting co-benefits. There are
have fight the battle alone, but the doctors are more powerful people. So what do you think?
Well, I think everything needs to be evidence-based. That's why we need data, we need collection, and also, to influence our politicians. We do have a representative in the Legislative Council, so certainly we can reflect that. No, but I think overall awareness, that's why this forum is so important, and the first one, to really let people realize the if we were to influence politicians in changing city planning and all that. Of course, Hong Kong is quite aware of the need for healthy cities, and I'm sure space and all that is also part of it. But then let's work together. Let's gather the information so that we can make a convincing cases to our politicians in future planning. So I think with this, we don't want to waste your coffee time. Thank you very much, for attending this session. Are there any housekeeping issues that needs to be addressed?
Just a couple of housekeeping issues. In the event of perhaps a fire or some other public emergency, there are exits at the top of the stairs and down here, and you can proceed straight outside. Also, as we're now on the coffee break and time is limited, I would invite everyone to go straight outside for the group photo. And after we take the photo, then you can come in and have coffee and snacks. Also, the restrooms are on this bottom level out this door. They're on the level at the top of the stairs, and also upstairs, where we will have lunch, there are more restrooms. Thank you.